Hello. Now we're going to start section 3 of respiration, and in class we stopped before CP, cerebral palsy. So this is just to make the video shorter. I am focusing just on the last part that we did not address in class. So in terms of cerebral palsy, there are three major types. Number one is the spastic kind, which is kind of characterized by muscular rigidity, and there's weakness as well, but the muscles tend to be more fixed in a certain position, and they are rigid. So that is the spastic kind. Then there's athethoid, and then the ataxic kind. And we'll discuss each one in detail and see the speech characteristics, and we'll see the breathing characteristics, and then discuss the implications for treatment and the application of particular methods for each type. So as you see, because of the three different kinds, then that means there will be different techniques. And we always keep in mind that we need to individualize the treatment to focus on the patient, because every patient is different and every condition is different as well. So the effects on speech will change from case to case and from type to type. In terms of the spastic type, the structures again have hypertonicity, which means that they tend to be rigid, and there's weakness as well. Thoracic muscles are also affected, are weaker, and you can imagine that it's gonna restrict the ability to inhale. So when you do not inhale, you do not have enough vital capacity, you do not have enough air to start with, and that will in turn affect the amount of air that you can exhale. So that at the outset causes shallow inhalation. And also add to this that the person, when you start with a smaller amount of air that you have inhaled, you do not have enough, the expiratory volume will be decreased as well. But you add to that the effect of the rigidity and hypertonicity, that is going to cause some kind of movements which are forced, uncontrollable movements during exhalation. So that means the little amount of air the person has is going to put more pressure on that amount to expel it, and that will make the expiratory cycle faster than usual. So watch this video. I do not want to play any of these videos. You have the link already, so that not to increase the length of this recording. For the athethoid kind, it is characterized by involuntary movements, just random movements that interfere with the normal voluntary movements, especially for those for speech. So part of these movements occur on the level of the thorax. So the thoracic musculature and the movements will be abnormal, and that will cause irregularities in the inhalation and exhalation. As you know, these two cycles, inhalation, exhalation, have to be coordinated, have to be regulated. We said that in normal breathing, rest breathing, you begin inhalation takes about 40%, exhalation takes about 60%. For speech, under normal conditions, 10% inhalation, 90% exhalation. But that all is affected. These cycles become dysregulated in athethoid because of the unpredictable random movements that are affecting the thorax. So sometimes the person will have involuntary bursts of air during inhalation. Imagine you're just inhaling and you just that there's jerking or involuntary movements that's going to cause abnormal involuntary bursts. Also, that can occur during exhalation. So while the person is exhaling, they may put suddenly more pressure, so more air goes out at once, and that eventually will drain the exhalation volume. For ataxic, there is lack of coordination. So there is irregular breathing rates, irregular rhythm in terms of the size, say how much you spend in inhalation, how much you spend in exhalation. So if you change the duration, for example, from 40 to 60, you make this one longer or shorter, that's going to lead to irregular rhythm. Irregular depths of tidal breathing. So that is at rest when the person is breathing, they do not go all the way, like they do not inhale the full amount that under normal conditions the person should have, or exhale the normal amount. So that limits the amount of air the person would have, even at rest. In terms of respiratory features, we're looking at all of these, but we'll individualize for some as we go. So the four respiratory parameters are affected. Recall that these include lung volume, they include pressure, flow, and wall movements, the movement of the thoracic wall. So every aspect of this is affected in CP. The person would be unable to inhale or exhale normal volumes of air, and as you could see, that applies to all three kinds. So as a result, the person will use a greater portion of the viral capacity. In normal speech conditions, how much of the viral capacity do we use? So it is 20-25%. And now these patients already start with a low viral capacity to begin with. So that makes the situation even worse. And as they are exhaling, a lot of air is wasted, either at the level of the vocal folds, they are not adducting, compressed tightly, for example, oral cavity, along the vocal tract, poor control or muscular rigidity, and also at the lips. So all of these areas could be sources where more air could be wasted at this, which means that the pressure will decrease. So the more air you waste, the less the pressure is gonna be. In terms of clinical applications, for the spastic kind, the muscles are flexed all the time, and that you can imagine that that's gonna put pressure on the amount of air the person has, because we use the inhaled air during exhalation. So when these muscles just are contracting and putting more force, that leads to expelling the air at a faster rate. That means the person is not going to have enough to sustain one complete thought or one complete sentence while speaking. So over time, breathing becomes worse progressively over time. Also, vocal quality and loudness are being affected by that deterioration as the person continues to speak, and as they begin speaking. For example, at the beginning, if you speak for 20 minutes at the beginning, they are at the best that they can. But as they continue talking 5 minutes more, 10 minutes more, 20 minutes more, speech quality and loudness, they deteriorate as well as time goes by during a conversation. For the athetoid kind, the child gains more postural stability with age, so that type shows more potential for bigger improvements. In addition, in terms of speech, one big piece is to focus on strengthening thoracic musculature. And for example, when you have ways to make the person push air out under resistance, to have a boundary to resist the airflow, that's going to make the person have more control and use the expiratory muscles more. So for example, one of these techniques is to use a face mask that has a valve, and the valve has a certain strength. It requires a certain amount of pressure to be able to open it with your breath. So every time the person exhales, they put that amount of pressure and they use expiratory muscles more actively. And when they do this 15 minutes a day, that will strengthen these respiratory muscles, and that will increase vital capacity, and it will improve vocal loudness. We also work on improving the endurance for speech. So if the person, for example, we have a 15 or 20 minute conversation, so at the beginning they will start at their best and then they start to deteriorate. So the endurance for speech is poor this way. And one of the goals is to enable them to last for longer at a better quality and a better performance level. So this means we want them to get more syllables per breath, and also to lengthen, to increase the length of their utterances. So another kind of strategy or technique that we use is breathing exercises, and these breathing exercises improve control, breathing control, and improve also the coordination, so that the inhalation exhalation cycle can have a better rhythm. So this involves inhaling deeply and quickly. So then exhaling in a controlled, slower manner, because one of the problems, for example, is that the person expels air quickly. That will also, one of our goals is to facilitate deeper inhalation, and that is going to increase lung volume and pressures. Because you remember these 4 criteria, they kind of build up on each other. So one of the exercises involves sniffing during inhalation, for example, like that, to raise more awareness of the air flowing in, and also to increase the volume for inhalation. And another exercise is to blow on exhalation as the person is exhaling, to blow air out, or to blow bubbles in water, because water is going to increase, it has resistance. When the person is using a straw and blowing bubbles in water, that means they can have some resistance, and that means they put some more muscular force. And then alternating between the two, sniffing and blowing. There are devices that are used to improve posture. Recall that posture directly influences volumes and the pressures we have. So having certain tools to improve posture is going to produce immediate improvements. There are various devices that are used for improving posture, and that includes braces, corsets, wraps, like, belts around the waist. And sometimes the seat that the person is sitting in could have belts, and you just bring them up and you put them around the shoulders, and the person will be sitting up more up straight. So this is going to improve all the 4 parameters, and that will result in better exhalation, better lung volume, better maximum inhalation and exhalation, and also in turn that is going to improve pressure and airflow, and will maximize phonation time and the ability to pause at the predicted positions when you speak. Juncture is the silences that you put while you are speaking. That is, in writing, we put punctuation marks to mimic the pauses that we make as we speak. So that is what juncture is. And of course, you can imagine if the person doesn't have enough air, for example, as they are speaking, they would not be able to reach the normal place where they can pause in the sentence so that they can continue. So they might pause prematurely, and that will cause disfluency. In terms of respiratory function and voice disorders, there are many voice disorders. Some are psychogenic, some are organic or caused by anatomic abnormalities. Some are caused by neurological, problems. So in terms of, again, treatment and intervention and stuff, there is a lot of focus on individualizing and personalizing your treatment, because every case is different. Every disorder is different, and you have to look for what works best for your patient. That's a big part of any treatment that we do as speech pathologists. So as a rule, again, when we speak at a volume that is lower than the respiratory end level, that will cause us to it will force us to use the accessory muscles of exhalation more. And recall that during rest, the diaphragm is the primary muscle that is used for tidal inhalation and exhalation. And once you go beyond that, for example, for speech functions, you are going to have to rely on the expiratory muscles to be able to compress, to use the abdominal muscles, for example, to compress the viscera and to eventually put pressure on the diaphragm and then narrow the lung volume using the abdominal compression. So that is muscular tension. That is part of accessory muscle use. And also we studied the muscles of forced exhalation, and they enable the thorax to compress more. So when we begin speaking at a level lower than the tidal exhalation, that means immediately you start to speak and you have to rely on the forced expiratory muscles. And then that means that will result in more effort, and it will make the process tiresome, and will put in a strain on the muscles. So eventually that is going to cause greater vocal fold tension. And when you do that, there will be a lot of tension in muscles that should not be interfering much. And when that continues, of course, that will cause a problem after another. So there are several types of voice disorders associated with respiration abnormalities, and they include nodules, polyps, and vocal fold fatigue. So in terms of nodules, we have seen many images and of that hourglass configuration where the nodules just protrude to the midline, and you bring the vocal folds together and they are not closing. The vocal folds just meet at the spot where the nodules are, but then above them and below them there is a space where the air just leaks out. So that is going to affect the pressure. It will affect how much air you will have left in the lungs that you can use to speak as you continue speaking. Nodules begin due to in terms of vocal nodules, the disorder itself occurs. It is behavioral in nature and occurs due to excessive speaking, screaming, yelling, singing with no techniques or no training. Also, remember that some of the categories that have a greater percentage of vocal nodules are teachers, singers, and children. In terms of, yes, we will discuss the treatment for nodules. However, there are two situations. If the nodules occur, you catch them when they occur, the person will have a better chance for behavioral treatment. They will improve with behavioral treatment that you do as a speech language pathologist, because that is one-time event, and the tissue can go back. If the person has a vocal hygiene program that is well designed to increase vocal fold hydration and to seize and diminish the behavior that is causing the problem, for example, decreasing the amount of hours speaking under, if the person has to speak in a noisy situation, they should use a microphone or come closer to the person. There are a lot of techniques for vocal hygiene. So that will work. Again, you can totally improve the condition with behavioral treatment, just speech language therapy. However, if the problem has been there for a long time and the person has been a voice abuser for a long time and talks excessively, and these nodules have been sitting for months and months, and the behavior is continuing, the person will have to have surgery. And the physician most likely is going to ask for the vocal hygiene program to be implemented before the surgery. You have to ensure that the behavior that causes the problem ceases to exist. And once you ensure this and you teach the person and prepare them and work on that, then it would make sense to have the surgical treatment, so that when the person corrects the problem this way, it doesn't come back. So otherwise, the same problem will keep going back. So what is the use? Polyps are growths, abnormal growths that develop for for a variety of reasons. They develop on the vocal fold, sometimes on the edge, sometimes on top, sometimes below. But in any case, when you put a polyp on one vocal fold, it will make it thicker. It will make it heavier. It will make the vocal fold not vibrate at the same rate as the other vocal fold. That could cause something called diplophonia, where the voice, you have two different sounds coming out of the vocal folds. In addition, so many of the polyps are going to interfere they will come between the vocal folds and will prevent them from complete adduction, and that will cause a lot of air to leak out. And some of these polyps can be quite large. So they will, again, in some cases, if they are new, the tissue can heal and there wouldn't be a need for surgery. But if they are there for a long time, they may need surgical intervention. So this, again, most of the problem is that the air just leaks out at the glottis, because the problem causes the vocal folds not to come to be approximated and have compression that is needed for speech. The same can happen for vocal fatigue. In terms of the respiratory features for vocal nodules, there are several abnormalities that they exhibit, the patients exhibit, including larger lung volume excursions. It means that they go out and in, they would require, it involves more energy, the inhaling and exhaling. And when they begin the inhalation process, they have a higher lung volume. And because they know they're going to lose a lot of it when they exhale. So when they terminate, when they stop towards the end of speaking, they have much lower volume, because they put a lot of pressure at the end. So the patient inhales at abnormal viral capacity levels and expends a higher percentage of the viral capacity during speech because of the leakage, because of the wastage of air that results at the glottis, results from the lack of closure. They will be producing a fewer number of syllables per breath, and they will end speech significantly at a significantly lower volume. That, remember, when you go lower, you have to exert a lot of muscular force, because this is how you can put the pressure on the lungs to increase the pressure in the lungs in order to expel the air. The patient initiates speaking below the resting expiratory level. So these behaviors result in increasing tension, increasing stiffness of the vocal folds while phonating, and that will bring in a sequence of problems that result. So the increased stiffness will increase tracheal pressure, and of course the increase in tracheal pressure is going to increase vocal fold hyperfunction, and that causes shallow breathing, poor coordination of expiratory functions, and phonation. And it will also lead to an abnormal pattern of breathing that we know as clavicular breathing, elevating the clavicles here while you are breathing, and that that is a kind of breathing that we discourage significantly. We discourage because it will put a strain on the musculature, and also it will not produce a lot of expansion, because recall that the pieces of cartilage on the top, on the front of the thorax, they begin as tiny pieces, and they extend and become longer as you go lower. So that means up here there is not much room to expand anyways. So the clavicular breathing is just going to involve a lot of muscular force and tension, and it will cause the whole area here and the neck muscles to be tense. So in some cases, vocal nodules will also cause fatigue because of the excessive muscular force that they are using. In terms of clinical implications, we focus on decreasing the use of lung volume below the resting expiratory level, so that the person, they can begin with a greater amount of air. That means they wouldn't have to rely on muscular energy of the accessory muscles too early. So they can be kind of start almost like the normal levels. So also pausing and releasing breath at appropriate intervals to replenish the air supply as we speak, but this has to be regulated by the pauses they have to make, and this has to be regulated by the linguistic content that they want to convey. And doing this is going to improve lung volume as well as voice quality. Now we switch to stuttering. Stuttering, there are a lot of variations, from person to person. And this is why you have a lot of diversity in terms of what features, what characteristics. And this again requires that we focus on the needs of that particular patient based on how they present. Respiratory features include abnormal respiratory control, especially during inspiration, during inhalation. There's incoordination between abdominal muscular activity and thoracic muscular activity that will cause a problem because these need to work in sequence. For example, the thoracic muscles will contract, the diaphragm goes down, and it compresses the abdominal viscera. The abdominal viscera will extend the abdominal muscles out. And so in that sequence, that is for normal speech, but that is not always the case for people who stutter. There's irregular respiration cycles. That inhalation, exhalation, the duration of each one is not going to be the same. Also prolonged expiration. Sometimes the person will as they exhale, it should be 90% of the cycle, they might take longer. And sometimes they might take longer inhaling. Instead of 10% inhalation, they might take a longer time. Sometimes they completely block. We call them blocks, like especially on the stop sounds. Any sound that is a stop, they have a difficulty releasing that stop. So it could be or t, t, or d, or g, g, or the So then over time, this cessation of airflow, these blocks, will lead to abnormal secondary movements. We call them secondary features of stuttering. That means, for example, shaking the head, tilting it back and shaking it, and then having tremors around the mouth, and a whole set of secondary features of stuttering that occur when these blocks come. But these result from completely, when you shut the airway, when you make the stop sounds, and they just can't release the stops at the normal times. The person might, at occasions, phonate while inhaling, and you can imagine how hard that could be. And also, they might interrupt the expiration by inspiring while they're expiring. Like they are exhaling, and then they just all of a sudden, in the middle, interrupt and inhale. So the disruption of the normal rhythm of phonation. As a matter of fact, stuttering is known as a disorder of fluency and rhythm because of the breathing component. they would, the volume will be low, voice will be sometimes low, and the person might terminate speech below the resting expiratory level. That means they have to put more pressure, they have to deploy more accessory muscle activity. And that's from the beginning, towards the end. So when speaking, lung volume is mostly in the lower half of the viral capacity. Again, that means they need to put more muscular force. That increases the tension that they have. And they had difficulty controlling subglottic pressure. Remember, subglottic pressure is what drives vocal fold phonation, vibration. And if you decrease it or increase it too much, that's going to affect the speaking. Here are a number, the whole set of cases that you could see, and you can see they speak about their own stuttering and how they feel about it. So when we look at stuttering, we need to compare it to normal speech. Normal speech production involves a gradual build-up, of pressure, for example, and phonation occurs in either one of three situations. It can occur shortly after maximum pressure. In some cases, for example, the person is singing or speaking at a louder voice, or simultaneously, or shortly after the maximum pressure build-up. In terms of stutter speech, they build up, there's a smooth build-up in terms of pressure, just like a typical speech. However, the time for initiating phonation is not the same. So it is an altered initiation time. So there are several ways that will be altered in several different ways, depending on the patient, depending on the situation. So in some cases, the patient phonates long after the maximum pressure is reached. So what does that do? You achieve maximum pressure. You can speak, your voice will be projected, you have enough air and all of this. But the longer you wait after maximum pressure, the more air is going to be released, the less you have in your lungs that you can rely on. So eventually that makes the person run out of breath faster. That will make their volume lower, and that will lead to a whole sequence of problems. In some cases, there is an irregular increase in pressure before phonation. So you just put more tension, and that means you start at a louder volume all of a sudden, and all that tension is going to expel more air, and that will also lead to problems. So pressure sometimes is abnormally high at the beginning, but then it just drops, and it will not be sufficient for phonation towards the end, because the person just runs out of air quickly. And sometimes pressure is extremely slow to build up, and the phonation begins at the lowest possible level. So that means there's a lot of muscular tension that from the beginning of speaking you have to put in. And again, all of these are different scenarios, and that will be different from person to person. Sometimes it is even worse when the same person will experience different different scenarios in different situations. For example, if there's a anxiety, or if there is a new situation, or if the person is tired or didn't sleep well, and so on. In other cases, sometimes the speech gets interrupted by quick diaphragmatic contractions, almost like the hiccups. The hiccups are caused by the diaphragm just, pulling or contracting, out of control. So these contractions will decrease subglottic pressure. Imagine while you are exhaling, the diaphragm should be rising, and that will put more pressure on the lungs to narrow their volume, to increase the pressure of the air going out. But instead of rising, the diaphragm, when it contracts, it's gonna go down. So imagine you are speaking and you need the diaphragm to keep going up, but then it goes ping, and it just goes down all of a sudden. That means it will take the air down with it. It means it makes subglottic air pressure lower all of a sudden, and that makes the person, be unable to generate vibration. So under these conditions, the person, there's lack of expiratory muscle activity, and that will lead to failure and the buildup of subglottic pressure. And that definitely will make the person kind of gasp for air or stop speaking. In some other cases, the patient may exhibit excessively high subglottic pressure because of excessive muscular activity or contraction, and that leads to excessively high subglottic pressure will lead to abnormal loudness at the beginning, and as they continue doing this, the air is going to decrease. The air pressure will decrease. You just want to control it and keep it trickling out, the air released at a steady volume, so that you can make it continue 90% of the cycle, so that you can use it functionally for speech. Anything that disrupts that normal rhythm, normal flow, is going to affect the volume, and it will affect the pressure. So one of the major features, because again, we are discussing the features just that have to do with respiration. We're not discussing any other aspects here about stuttering. So regulating the breathing, that's the big piece in stuttering treatment. And there are three approaches that focus on regulating breathing. One of them is the regulated approach. And these are, quite old, but they have been effective. The regulated approach aims at increasing awareness of how to breathe, inhale and exhale, and increasing, for example, the contribution, how the awareness about how breathing contributes to fluent speech. And this comes by giving exercises and inhaling, exhaling under different conditions, modifying breathing patterns, with teaching the person to avoid clavicular breathing and to focus more on abdominal and thoracic breathing. Also, part of this is to relax the thorax and the laryngeal muscles using exercises like for example, laying on your back and inhaling and seeing the abdomen just go up, and exhaling, seeing it go down. And that will be effective in teaching abdominal breathing under these conditions. Teaching the patient how to pause when anticipating stuttering. Like there are certain words people who stutter will know. They start a sentence and immediately say, "Oh, that word is coming and I know I'm going to have trouble at that word, they teach them to pause. And then continue speaking. So speaking in short utterances, because they can control them better, and then increasing the length of utterances gradually. For the second approach, the Murdoch and Mccall approach, they focus on slowing the rate of inspiration and teaching the patient how to use diaphragmatic and intercostal breathing, at the same time avoiding clavicular breathing. And that was found to increase abdominal and to reduce abdominal and thoracic and movements, while also decreasing the stuttering behavior. The third one is the Walter Reed Stuttering Program, and that is designed to increase abdominal breathing and to establish adequate volume and breath support. Also maintaining airflow continuously by, we call it continuous phonation. Like when the person is going to use a stop sound, you teach them to just continue to phonate, keep the airway open. And the patient, one of the advantages is that they can look at a computer screen and get feedback from the computer screen as a result. Now we switch to asthma. Asthma, we really do not do as much, but the fact is that it is something that is more recently the speech-language pathologists working in hospitals in particularly are more involved in it, and they do make a big difference in terms of the treatment for people who have asthma and voice disorders. So asthma is caused by inflammation of the linings, the epithelial linings of the airway, like the trachea and the bronchi. So there's swelling, and that is an immune system reaction to a substance or something the person smells or ingests, and as a result, the upper airway or the lower airway just becomes expanded as the immune system brings in fluids like white blood cells and chemical materials to fight what is suspected to be an invading germ or bacteria or whatever. And as a result of that swelling, the airways is constricted, and that is called the histamine response. It's a normal response that, for example, when you have a cut, you get the histamine response so that you can heal that cut over time and bring in immune system elements to heal it. But when it involves your airway, that is gonna be a life or death situation. So the antihistamine medications are going to cause to reduce that swelling, and it will open the airway. Asthma is associated with a nighttime cough, with dyspnea, and when the person especially puts, is physically exhausted, for example, or works and exerts muscular effort. There's a chronic throat clearing because a lot of mucus is released, and post-nasal drip and so on, chronic cough, and chest tightness. In terms of acute attacks, misspelled. These include dyspnea, on expiration while exhaling, the person will feel shortness of breath and also chest tightness. In terms of the treatment, of course, there is medical treatment that we as speech-language pathologists, we have nothing to do with. These physicians, give the appropriate treatment We just deal with the symptoms that have to do with voice or voice abnormalities. So the physicians administer corticosteroids, like inhalers and so on. But that, causes hoarseness. And this is where we come in and, we try to work on things like these, because that's a voice problem. And some treatments combine both corticosteroids and bronchodilators to open the bronchi. Voice characteristics include mouth breathing. When you breathe through your mouth, you dry the vocal folds more, you expose your oral cavity more to germs, and there are a lot of abnormalities that involve mouth breathing. The person would exhibit dyspnea and clavicular breathing because they're gasping for breath, and that decreases vocal loudness and causes hoarseness. They also have labored breathing and wheezing at times that causes vocal fold inflammation, and that, of course, will cause poor vocal quality. And these are the things that we, as SLPs, work on. Lastly, there's paradoxical vocal fold movement. From the name, you understand that the movement of the vocal folds is not regulated. It is not smooth. It is, in the real term of the word, meaning of the word, paradoxical. So there's inappropriate spasmodic vocal fold adduction while inhaling, and because of the disruption of coordinating speech and phonation, the person will have this problem of paradoxical vocal fold motion. So one of the major features is stridor, and we showed a video, and we said stridor can come in inhalation most commonly, but it also can come on exhalation. That high-pitched sound during as you inhale and you make that sound. But in paradoxical vocal fold motion, it occurs in inhalation mostly. There's dyspnea, chronic cough, GERD, gastroesophageal reflux disease, postnasal drip, and allergies. Respiratory features including normal spirometry values, like volumes are okay, capacities are okay, normal oxygen saturation. But when there's an attack, that reduces oxygen, and it reduces vital capacity because it reduces the amount of air that a person can take in. And there's greater flow on expiration than inspiration. That means the person is gonna run out of air quickly, and that means they will have to rely on more muscular force. And that will affect pressures and lung volume. So a reduction in the amounts of air inhaled. If you start with a small amount in the first place, you are not going to have enough to continue speaking. You will also have limited exhalation volumes. So to some extent, expiratory amount may also be reduced. And again, that is because you start with a lower inhalation amount. For treatment, in terms of the acute attack, the focus is on respiratory training, voice training, and the medication part that the ear, nose, and throat doctor is going to give. For long-term also, we have respiratory training. So respiratory training is part of both. And the purpose of this is to train, to relieve the discomfort and reduce the pressure from the larynx. That is one. To relax the abdominal breathing, to make it use abdominal breathing more effectively so you can take air in more, and expand abdominal volume during inhalation and compression. And also during to teach the person to increase abdominal compression while exhaling. and also to maintain steady shoulder position and steady neck and mandible postures while speaking. For long term, also there is relaxation exercises informing the patient and increasing awareness about how to use their vocal folds and how breathing relates to vocal fold function and vocal fold hygiene to simply control the cough and throat clearing. So that brings to conclusion this part. And next time we are going to speak about inhalation, phonation. Thank you.